Chris.
Hi.
Welcome to South Africa, firstly, and thank you very much for your time that I can just pose some questions.
It's my pleasure.
Thank you very much. So my first question really relates to the Geko device.
Okay.
And can you maybe just give us a brief overview on the primary function of the Geko device?
Yeah, of course. So basically, the Geko device is a device that improves blood flow in the lower limbs. So the way it does that is we activate a nerve called the common peroneal nerve, and we use the motor function of that nerve to activate muscles around the calf and the peroneal brevis and longus, which are the foot muscles. So we create a movement a little bit like a patient would get if they were walking. And that drives venous blood back to the heart. And then, of course, in the pump system, we then move arterial blood back to the lower limbs and see some benefits also in microcirculation.
Okay, fantastic. I see you have a sample here today. So it pretty much looks like a wristwatch, right?
It does. It's 10 grams in weight. It's a what's called a Class 2A device. So it's a disposable single patient use.
Yeah.
And you can use the device for three main indications. One is edema, so the prevention and treatment of. Second one is for wound healing. And the third one is for deep vein thrombosis prevention or prophylaxis.
Okay.
It's a prophylaxis device. But the way it does all three of those things is through blood flow, blood movement.
All right.
On the back, there's some electrodes that deliver power to the nerve, and there's a little battery in here, so the battery's a self-contained unit.
Okay.
This particular model will run for 30 hours, continuous use.
And I mean, the fact that it looks like a wristwatch, where is the application? So if I look at it, it's easy to understand.
Yeah, so you don't want to stick it on your wrist first and foremost. So basically, it fits around onto the head of the fibula, so just to the right of your knee, left or right leg. Certainly on the right leg, it's to the right. And you're targeting a nerve there called the common peroneal nerve. So you use that fibula head anatomical marker to place this little marker on the device over the top. And on the back of that is an electrode. So these two electrodes here, this one and this one, have to touch the skin. This third one is just a holding position.
Okay.
So it can be over a bandage should it need to be, certainly in a midline incision such as knee surgery. So it fits any size patient, but the fitting is down below the knee.
Okay. And I see it has a little plus and minuses, so you can use that to set the frequency, or what are you setting there?
You're setting, there's 10, on this device there's 11 settings, on the wound version there's 10. What it basically does is it increases the duration within each cycle, the energy delivered. So the energy is a constant for the first 7 settings, at 27 milliamperes, and it jumps to 38 at levels 8 and 9, and at 10 and 11 it goes to 54. The reason that we've built it that way, and you increase the level by pressing the plus button to go, is that patients come in all ranges of sizes, weights, but also with underlying conditions such as neuropathic disease, grade 3 edema, that type of thing. So you need more power to get to the nerve. So when you set it for a patient, each patient will be different, but you just keep increasing the plus button until you physically see the calf muscle contract and the foot lift of dorsiflex, and that's the optimum level for your patient.
All right, thank you very much. It seems pretty straightforward.
It is.
So my next question really relates to exactly what is an NME, all these acronyms in our industry, and how does it differ from other muscle stimulation technologies?
So NMES it basically translates to neuromuscular electrostimulation device. In simplistic terms, that is that we use a nerve to activate the muscles, and in our case, that's the common peroneal nerve. A TENS machine is basically a signal blocker, so you're trying to block the nerve from conducting a pain signal to the brain. The issue with TENS versus Geko is that Geko, once you reach the stimulation of the motor function of the nerve, the patient doesn't build resistance to it. With a TENS, because you're blocking a signal, the body's quite smart and it works a way around the TENS machine. So you have to keep turning up the power until the point where a TENS machine doesn't work. And women in labour will tell you after a period of time, TENS just blocks, it doesn't work. Direct muscle stimulation or electrical muscle stimulation is you're putting voltage directly into a muscle to get it to contract. So you tend to need much higher power, and it tends to be quite uncomfortable for the patient. So that's the difference between the three.
Okay, thank you. So how does Geko's NMES technology specifically enhance the blood flow?
Yeah, so the technology inside Geko is called OnPulse. It delivers a particular waveform that targets the motor function of the nerve. So we're not looking at the sensory part of the nerve, we're looking at the motor function, the bit that would actually activate the muscles. So basically the way the waveform is designed, it's a balanced charge rectangular waveform. The closest to it is a pacemaker, cardiac pacemaker waveform. They're virtually identical. So what happens is it delivers it, and then we throw the device quite cleverly with the electronics, throws in similar power at the back end of the delivery to make it balanced charged, and as such then you don't get any skin heating or residual problems with it.
Okay. When you mentioned a pacemaker,
yeah.
So if the patient that we're dealing with has a pacemaker, is there any interference with the pacemaker?
We are still to find any, but we do have it in our instructions for use as a warning. If the patient is pacemaker dependent, it's probably worth just double checking. And the easiest way to do that is to put on the remote wand, pull up the intracardiac electrograms from the pacemaker and switch on the Geko. You would instantly see what's called crosstalk or interference. We have done a pacing paper which is about to be published. We haven't found any mode of pacing that is interfered with by Geko. But that doesn't mean there isn't one out there. We just haven't found it yet.
Thank you. Thank you for the transparency. I also want to ask, what is your research showing as far as the effectiveness of the use of the Geko device?
Yeah, so as I mentioned earlier, it's got three primary indications. One is for wound healing, and we focus on non-healing ulcers of all etiologies, but predominantly our work so far has been in venous-led ulcers. We look at edema as a prevention and treatment of. In terms of the prevention, we're looking at pre-operative swelling to get the patient ready for the OR quicker. Post-operatively, it's dealing with the complications of a trauma of, say, an elective procedure such as a knee, a hip, or foot and ankle. And the deep vein thrombosis side is purely as a prophylaxis or preventative, where primarily the patient cannot be prescribed drug therapy or blood thinners because of the risk of bleed. So they're usually a post-op patient or somewhere in the region of a stroke patient, for instance, has had an ischemic or a hemorrhagic stroke. You don't want to exacerbate that by thinning the blood. So the research-wise, we've worked extensively in chronic ulcers. So these are wounds that aren't healing. So to define a chronic ulcer is something that's not healed by more than 30% in 12 weeks. So usually what you find is the patient is stuck in what's called the proliferation phase of healing. And that's down to an insufficient blood supply into the wound and surrounding wound bed. The Geko supports that by bringing oxygenated blood. So as we get the arterial return, we see a big drive in microcirculation, so blood in, blood out to the wound bed. We also manage the swelling that could also be delaying the wound healing. So edema dilutes nutrients, you take care of the edema, and then you put blood into the wound bed. From a deep vein thrombosis side, we've got quite extensive data now in stroke patients, neurosurgery patients, both intraoperatively and postoperatively, and also in ICU patients. We've also done little bits of work in cardiac ICUs and bariatric surgery procedures. The edema side, we've really focused on preoperative, which has been around ankle fractures. So these patients present with swelling, with broken ankles that need surgery, but the surgeon can't operate until the swelling is down to a sufficient level. In the post-operative phase, we've got now randomized controlled trial data looking at swelling in hip surgery, knee surgery, foot and ankle surgery. And what we're seeing with that is if you control that swelling quickly, post-operatively, the patient's rehabilitation journey starts to look very different in terms of the amount they can move in those first weeks after surgery, in terms of the pain they're experiencing in those first weeks after surgery. And in the foot and ankle more recently, we're starting to see an improvement in total healing of the actual surgical side.
So what I'm hearing and understanding from what you're explaining, that there's a benefit for, in South Africa, we typically see funders as medical schemes and then obviously vendors of medical schemes.
Yeah.
So there seems to be a benefit for both the funder and the client of the medical scheme. Can you maybe just unpack that a bit for me?
Yeah. So with all our indications, what we've always wanted to show with Geko is that there's a clinical benefit for the physician, a clinical benefit for the patient, but also releasing of savings for the funder or the provider. Mm-hmm. So we back all our research with economic data that supports those benefits. So with wound healing, for instance, because we heal 2.2 times faster, there's a benefit that you close that wound earlier. For the payer, the nurse no longer has to visit that patient 3 to 4 times a week, apply bandages and dressings on that.
Yes.
For the patient, they're in less pain and their quality of life improves. With the oedema side, if we accelerate that rehab side, the patient's back to a normal life and moving. And you also avoid those complications of a patient becoming immobile and getting muscle wastage and nerve damage and things of that nature. And in DVT, it's a real sitter because any DVT complications such as post-thrombotic syndrome or symptomatic VTE or pulmonary embolism carries a high cost within the hospital setting to sort patient, but also risks the patient's life.
Mm-hmm. Thank you. So can you explain just a little bit how the Geko device actually, how it activates the calf muscle without the need of any physical movement?
Yeah, of course. So we target a nerve called the common peroneal nerve, which runs closest to the skin surface at the head of the fibular joint, which is why we pick that anatomical marker. At that point, the nerve branches, so it's the same nerve, but it becomes a superficial nerve, which runs down the front of the leg, and the deep portion that runs around the back. The rear nerve is linked to the extensor muscles, which are passively then squeezed around the calf. So it then squeezes the calf muscle, and then the superficial portion of the nerve links to the foot, so the peroneus brevis and longus, and that causes the foot to lift up like this slightly in what's called a dorsiflexion movement. So when you walk, your foot lifts and you apply the weight through the calf, which squeezes it. And we do that when a patient's not able to move or is immobile. So we get about 60% of the blood return that your patient would get if they were walking. And the difference being that the patient's non-weight bearing, which is your additional 40%.
I'm interested in some of the results of your studies. I think you can maybe talk to me a little bit about a patient that you've seen. What was the longest time they were struggling with a wound to heal, and what the effect was on the Geko in terms of now you're getting this patient that's been struggling for a long period of time?
Yeah. So we have a randomized control trial in venous leg ulcers. The typical age of the ulcers in our group, the Geko group, was around 500 days. It was around 460 days, I think, in the non-Geko group. So that's how long that wound had been open and non-healing. What the study showed was that when you apply the Geko in combination with compression bandaging, which both cohorts had, we doubled the rate of healing. So what that basically means from a patient position is we get a predictable healing rate, but it means we close the wound a lot earlier. So in our cohort, bearing in mind the age of those wounds, 47% we healed at 28 days.
Sure.
And the remainder were on a trajectory to heal. Okay. So we have seen wounds open for longer than that, 10 years or longer, and we've closed those typically anywhere between 4 to 8 weeks, depending on the size.
And the age of clients using the Geko device, does it play a role?
They tend to be older anyway with venous leg ulcers or ulcers generally, but no, it doesn't. We see the similar rates of healing, predictable healing rates, regardless of the age of the patient.
And then I think specifically around wound care.
Yeah.
How quickly will the patient see results?
So we from the study, we say that you should start to see some movements of the wound margin from the outside to in, or the percentage area reduction in the wound bed within the first 14 days. And our advice is if you're not seeing any improvement at all after 28 days, it's most likely not a blood supply issue. You should cease using the Geko device. But typically 14 days, you're starting to see a difference in the wound.
Mm-hmm.
It might not be fully healed, but it should be on its way.
Okay.
Yeah.
Thank you. And then I want to talk a little bit. I think many of our funders or medical schemes are facing challenges with diabetic patients. So could you maybe just talk a little bit about the potential benefit of the Geko device for diabetic patients?
Yeah, sure. So diabetes, certainly type 1 diabetes, patients get something called neuropathic disease, which is a demyelination of the vein or the sort of venous system.
Yes.
But they also get ulceration.
Mm-hmm.
The issue with these patients is that you can't put them into some form of compression bandaging because you can't squeeze the artery. So they tend to be patients that become what's called offloaded. So they tend not to be moving around, which then exacerbates the ulcer itself or the condition of ischemia. And also you're limited with what you can do with these patients over that time. So they tend to be longer term. So with the Geko, we work exactly the same way as we would for a venous ulcer. We deliver oxygenated blood into the wound bed. So we do have studies from the Boson case study looks at arterial ulcers and do we improve microcirculation into the wound bed? The answer is yes. So we can see similar rates of healing, although we don't have a randomized controlled trial in diabetic foot ulcers. We can see similar rates of healing as we do in venous leg ulcers.
Okay, thank you. So could the Geko be part of a preventative care approach for diabetic-related care or wound care?
Potentially, if you have a patient who is at risk of a deep vein thrombosis or has some associated problems as a result of not moving, such as edematous legs where they're getting pain, yes, and you may potentially prevent that. We have no data on that because we've always, as a company, we've looked at actually closing wounds, not as a maintaining or preventing them from happening. But in theory, yeah, if you return blood flow to limbs in ischemic patients, arterial disease patients, then yes, there is a potential that you can prevent that happening. But we have no data to support that as yet.
Thank you very much. So my next question is, what challenges, in fact, because they're multiple, does Geko address for patients who are immobile or struggle to move around? Yeah,
so because we simulate walking, we're getting blood flow. So a lot of patients who are immobile, a number get edema or swelling in their lower limb, which they can't move, and that can cause them pain. Or they can ulcerate, which can cause them pain as a result of whatever level of chronic venous insufficiency they have. And also, a lot of these patients are offloaded, so they're not able to walk around. So where Geko supports them is it's moving blood around as though they're going for a walk. And that takes care of changing the pressure in the leg, allowing the fluid to drain into the lymphatic and capillary system. And also, if they've got an ulcer, then we're putting blood supply into the wound bed itself to support the body's natural healing process. So for those immobile patients, if you want to use it as a deep vein thrombosis prophylaxis device, if they can't have drug therapy for a reason that they may be at high risk of bleed or something similar, the Geko can also be one on each leg, on both legs to cover that off as well.
So you mentioned DVT. So can you just give me a little bit more explanation in terms of the Geko's role in terms of preventing DVT complications?
So most DVTs or most clots form in the lower limb because that's where the blood tends to pool when a patient's immobile. And some literature from Labropoulos from 1999 shows that those clots tend to form in the deep veins of the calf muscle. So the perineal vein, the posterior tibial vein, and the gastronomial vein. What we've shown with Geko with published data, so Nicolaides et al. Shows that our mode of action of Geko, the way we work and the squeeze we get on the calf, moves blood in those deep veins. at a statistically significant level. And it also shows that we move a high volume of blood. So as I mentioned before, 60% of walking. So when you look at it as a baseline, you or I sat in a chair, you could take a measurement in a popliteal vein or artery with a Doppler. You'd record that measurement and then you'd switch a Geko on, optimize it, and you'd look at the difference in percentage. So we know that that's over 100% in the venous and over 70% in the arterial flow. So from a deep vein thrombosis prevention, it's about how much blood you move, at what speed you move it, and how efficient you are at moving it in problematic vessels where blood can pool and potentially clot. And we tick all those boxes to the point where we have nice guidance on the use of the device from 2014, and we're using it a lot in stroke patients in the UK and in other markets.
So you make reference to 2014. So I mean, you're not new kids on the block. I think in South Africa, the Geko device has received SAPRA approval in August this year. So talk to me a little bit about is there, other than the SAPRA approval in South Africa for the device, FDA approval?
Yeah, absolutely. So the device the T device, which is the device used for edema and deep vein thrombosis prevention prophylaxis, is both CE marked, which was now transitioning to MDR, which we've completed the paperwork for, so we're a class 2A under MDR from 2028, and also we're 510K FDA approved for edema and DVT prevention. On the wound side, we're CE marked, and we have a sort of hybrid FDA approval about putting blood flow into the wound bed in venous leg ulcers. So we're working on that as the next stage. We've also got approval in other markets, Canada, Australia, Saudi Arabia, and we're working on our CE marking and registration in Japan, currently in Russia, and also for listing in Germany as well. So that's the with devices, it's around building data sets in around clearing regulatory and reimbursement hurdles. And it saddens me to say it, but with any new technology that doesn't have anything else similar to it in the market, you have to create your own category, and you have to clear those hurdles. And that's a costly and timely process.
Yes. And I mean, that's why some of that regulatory approval is so important in new markets. And obviously markets in South Africa, we have that approval now through SAPRA.
Which is great.
So can you talk to me about some of the unique features of the Geko that differentiate it from other NMEs in the market?
Okay, so first of all, we're the only NMES device that locates on the head of the fibula to the common peroneal nerve. But if you look at technology that some could say is roughly similar, the main difference with the Geko is, first of all, its portability, it's disposable, it's lightweight, it's very easy to fit, and it will fit any patient size. So I guess another unique thing with Geko is we cover multiple indications with the same device. So if you want deep vein thrombosis prevention as well as managing edema, one device will do both jobs very effectively.
Right, fantastic, thank you. How safe is the Geko for long-term use?
So we've got data now, as you mentioned, in DVT. We've been out since 2014. So in terms of long-term use, we've got quite a pool of patient usage and data. So we haven't seen any issues with the Geko in terms of nerve damage, skin heating, that type of thing. And we're on probably our third or fourth iteration of the silicone hydrogel compound on the back, because when we move to wound patients, we have to balance the stickability of the device with the fragile skin of these patients. So that's an ongoing issue. From the company side, we're constantly innovating and looking for new ways to maximise the Geko in those patient groups. So that really is I guess, does that address your question? So we don't really. I mean, we've not had any real issues with the device. We've had anything comes in through our patient management system, through our compliance system. So we have got that data available for auditors to look at, and we're constantly. This is a T3 device, so this is the third generation of this device, and Where it differs from T1 is we've listened to clinical feedback and we've put those features in that both clinical and patient feedback has guided us to evolving the next platform within this technology. And we've had the same with the wound. So we've changed the programmability of it. We've changed the power settings. We've changed the hydrogel. We've changed the spacing. We've changed the strap length, the configuration of the device. So it's an evolving product. And that evolves through market experience and feedback, which we always welcome from both from patients and from payers and physicians.
Yes. So let's talk a little bit about the typical protocol. So you mentioned it has, let's say, 30 hours on it.
Yeah.
How is it used practically by either the patient when they take it home or when the wound care practitioner applies it?
So with the wound product, it's packaged in a 14-day treatment pack. And within that pack, there are 7 singly packed Geko devices. There are 14 adhesive overlays to help hold it in place and support it. And then there's instructions for use. So what would happen is the patient initially would be trained on fitting the device. And then when you switch it on, the device has a timer built into it. So with the wound device, it will give 12 hours of therapy, and then it will switch itself off. And it won't allow you to switch it on for a 6-hour window. So we want to encourage the patient to give their skin time to relax between therapies, also to clean the area to prevent any sort of build-up of residue from the gel, etc. Now, we know patients not waterproof, so patients might want to shower or do something, or maybe go to the shops or something in that 12 hours. So cleverly within the wound device, within the W3, the device calculates if you switch it off, and you're allowed up to 3 hours of being switched off in any 12-hour treatment cycle. And it just calculates itself how much of the 12 hours is left. So it will always give the patient 12 hours of therapy before it shuts down. And the next day, the patient puts it back on and carries on. So it's each device will give you 2 days of treatment. So that's the W. The reason we can't use W for things like DVT prevention is that it switches off after 12 hours and you want continuous blood flow. So for deep vein thrombosis, the T device, you switch it on and it will be usually in a hospital setting and there'll be a device on each leg. So it comes in a package of 2 like this and you put 1 on each leg. That will be optimized by the nurse because generally these patients are immobile and under nurse care. At 24 hours, they usually change it because you've still got a 6-hour window with battery life left to allow for that shift change in nurse patterns, etc. So 24 hours change for the DVT prevention. When we come to edema, if it's preoperatively, we'd run it continuously for 24 hours. And what we see then is a big reduction in the swelling and they're theatre ready, typically from the studies we have in less than 2 days versus 4/5 normally with elevation and ice. For post-operative swelling, and I can only go on the studies here for the protocols. So the protocols in the knee study we have, which we have data on file, is day 1 you would run on the operated leg the device for 24 hours, full day. Days 2 to 10 you would use it for 12 hours per day, similar to the wound. The beauty with this is you can turn it off at any stage in its 30-hour cycle. So in theory, you could, if you wish, take 2.5 days from each device from day 2 to 10 with the knees. On the foot and ankle surgery, our study looked out to 14 days of Geko use. So day 1 was 24-hour use again on the operated leg, and then 2 to 14 was at 12 hours per day. So how you would work with this would differ depending with the T device on whether you're using it for an edema indication or for DVT prophylaxis.
Okay. I mean, you said 24 hours. So if I use myself, I'm a very light sleeper.
Okay.
So if I would assume in that 24 hours, sleep has to happen somewhere.
Okay.
How will the patient be aware of it?
It's a great question. So initially when you put the device on, it's a painless stimulation, but it's like a tapping sensation. It's on a 1 hertz cycle, so it's delivering a pulse every second. The brain, in 99% of patients, after 20 minutes, makes it less aware that the device is on. Typically after an hour, patients don't know they're wearing the device, so the brain just tunes out the sensation. So we have very high compliance in all areas that it's been used over that time period, both in a clinical setting and in a real world setting as well. And I know from my own experience, if I put a pair on, I sleep in them. So I use myself as a control there. I've slept in them before, so you can sleep comfortably in that.
Okay. And then, could the Geko be combined with other therapies or treatments that enhances the blood flow and the health outcomes?
Yeah, so with wound patients specifically, we're not looking to replace anything else. So what we're asking is, when you've used your best standard of care and it's still not healing, you can then add Geko as an adjunctive therapy. So in venous leg ulcers, where you can compress and get a benefit, we'd recommend using Geko as an adjunctive therapy with compression, purely because when we get a calf contraction, it rebounds off the compression, so you're getting a better, more enhanced blood flow. It doesn't apply in arterial or mixed ulcers because you don't want to compress the arterial component. That's not good for the patient. So you can use it with post-operatively with a combination with surgical stockings if you wish, because stockings really have no benefit as DVT prophylaxis. They're good for edema, but they're not so good for DVT. So you put the two on, you're enhancing that effect in a similar way you are with compression, bandaging. So you can use it pretty much with anything else if you should wish to do so.
Thank you. And then we obviously will have some healthcare professionals listening to this interview. And what advice would you give to the health professional in terms of if they're interested in the use of Geko and they have obviously patients with the different applications you've described?
My advice would be, first of all, to use it. Because that would be the answer you'd expect from me. But no, I would use it in where the science is guiding us with the Geko. So for DVT prevention, we have very clear guidelines in the UK from NICE that you use this when you can't use drug therapy because there's a bleed risk to the patient or a contraindication. So this is not a long-term DVT prophylaxis device. It's the short-term strategy to get people to the point where you can actually put them back on a drug regime or get them mobilized. With the wound side, we're looking at patients that aren't healing. So many of these patients could have ulceration out for a number of years, which is a huge cost, not only to the payer and the health system, but also horrible for the patient because they're in pain, it's affecting their quality of life. And with the edema side, patients want to recover. They either want surgery quicker so they can start that journey to recovery. And if it's a preoperative patient, most consultants would want them off their ward to free up bed capacity to optimize their theatre scheduling. If it's post-operatively, you don't want these patients coming back with post-op complications or being on longer-term physio and rehab programs because that costs the provider money and it also delays the patient's journey and recovery time. So I would say consider using this where you want a better outcome in a post-op phase for your patient, where you want that wound to heal to improve the patient's quality of life, and where you're looking at a mechanical prophylaxis for deep vein thrombosis in specific patient groups, usually within a hospital setting, but not always. For instance, in orthopedics, they may send patients home with pneumatic compression devices, but then they have to plug it into a wall and fit the sleeve. So this is very simple.
Yes.
It's a very elegant solution for that, and we move more blood.
Yes, and it seems to align with many funders are wanting to have the patient able to do care at home. So this seems to be very easy to use with very high effectiveness.
Yeah, absolutely. So for the DVT side, we tend to be more in a hospital setting, but it can be used for deep vein thrombosis prophylaxis at home if a patient's been discharged and they're not on drug therapy. For the wound, it's certainly a patient self-use product, so the patients will be trained how to fit it or their carer, and that would be administered at home. And on the edema side, that it's in a number of markets, the patient goes home with pairs of devices and a protocol from their physician on how to use. So you get the patient out of hospital, but you continue to work on that swelling
Yes.
and improve those outcomes that are associated with reducing swelling and managing swelling.
Mm-hmm. And talk to me, I mean, we've spent a lot of time speaking on was the medical side of it.
Yeah.
But what are there any, what you'd call them off-script benefits? Like, how, are there people that are using them that are not prescribed?
Yeah, I mean, it's first of all, it's a class 2A
Mm-hmm.
device, so it doesn't need a prescription to be used. A patient can actually buy it from a pharmacy, and a lot of patients can self-purchase. We'd recommend that they were guided if it's for specific indications by their physician or clinical partner. But certainly we get inquiries, or our partners get inquiries for buying this for flights instead of using compression socks. Mm-hmm. If patients have an ankle sprain or something like that to get the swelling down, they could buy it for that. Patients who want to recover quickly from certain things can put it on as a post-op recovery side. So it's not, it just comes down really as to how the system works for the patient to, if they're able to pay for the device, they can buy them. But if they want a reimbursed system through providers, then that's the clinical benefits we offer through in those key indications.
Thank you. And then talk to me a little bit as we close about future developments. You know, what other applications are you envisaging for Geko? I
mean, in the medium term, we will stay in the edema space, the orthopedic space. We'll stay in the wound space, but that will broaden with study programs to look at mixed and diabetic foot ulcers, arterial ulcers. There are plans to look at potentially maintenance of patients. So with wounds, especially, or ulcers, that you don't cure with this device the underlying chronic venous insufficiency or the ischemia. So the question that we get asked a lot is, how often would you need to use this once you've got the wound to close to prevent it re-ulcerating? So we'd like to do some work in that area as well. So they're really the ones that we're looking at. And potentially we have a study running versus intermittent pneumatic compression in stroke patients, which we're aiming to power to superiority. Should that be a positive study, then we would probably look at then building a device to maybe last a little bit longer. But at the moment, that people are very happy with the 30-hour battery configuration.
Thank you. Chris, thank you so much for your time. And we wish you safe travels.
Thank you very much.
Thank you very much.
Thank you for hosting me in South Africa.
Thank you.
It's been a pleasure.
Thanks.